Good morning, everyone, and welcome back to our Friday morning TIROxMDS programming. We have a terrific session set up this morning. For those of you who were at the World Congress last week, I hope that you had a wonderful time at that meeting in Boston. Tremendously successful meeting, and we as an organization had decided to skip our Friday morning session last week. So those of you who were not in Boston, and we welcome you back to our programming. I just want to advise everyone that this session will, as a recorded session, will become available in the coming days. And also would like to advise everybody that our monthly podcast, Voices of Wisdom, is really, really worth the listen. There is a recent two-part series for those who have not listened to it yet, with Dr. Mark Zafario, that is truly outstanding. And so these would become available once, I believe it's the third Thursday every month, but if you just check, it's truly outstanding. This morning, I have the distinct pleasure of introducing Dr. Masahiro Nakashima. He is a professor and chairman of the Department of Tumor and Diagnostic Pathology at the Atomic Bomb Disease Institute at Nagasaki University. His research is focused on endocrine and thyroid pathology. He has had a highly productive academic career and has had numerous leadership positions and also received numerous honors. He is discussing this morning the association between gross features of pathology, pathologic specimens in conjunction with BRAF and TERT promoter mutations. We have the honor this morning of having Dr. Ronald Ghossein as our discussant, and he is truly an outstanding individual to provide expert commentary on Dr. Nakashima's presentation. He's the director of head and neck pathology at Memorial Sloan Kettering Cancer Center. And for those of us who live in the thyroid world, he is truly a household name for his work in thyroid cancer classification, including his work on designation of NIFT-P as well as poorly differentiated thyroid cancer. His efforts in thyroid cancer risk stratification have had a tremendous impact both on the diagnosis and the management of thyroid malignancies throughout the world here. And so I welcome both Dr. Nakashima and Dr. Ghossein. Dr. Nakashima, if you'd like to go ahead and share your screen, we will go ahead and get started.
Thank you for inviting me to this wonderful program. My name is Masahiro Nakashima from the Atomic Bomb Disease Institute, Nagasaki University. So this is my disclosure and finding. We have no declare for the conflict of interest. So let me briefly introduce my institute. This picture shows Nagasaki Medical College. It is a predecessor of Nagasaki University, was completely destroyed by the A bomb in 1945. Approximately 900 staff members and students were instantly killed by bomb. This is a current image of University Hospital. The history of our university was started in 1857. Our university is the first medical school in Japan to educate comprehensively Western-style medicine. Our institute, ABDI, was established in 1962 for the purpose of comprehensive basic research regarding radiation medicine and the rate effects of radiation on the human body. As you know, most important rate effect of radiation is malignancy, including cell cancer. Therefore, it is the main reason for me to focusing on cell cancers as my research. So my topics today is about our paper published in South Journal last year entitled Association Between Growth Features and Coexistence of BRAF and TERT promoter mutation in papillary cell carcinomas, a combined analysis incorporating clinical pathological features. You can get this paper through this QR code. So in the pathological practice, gross examination of research organs is necessary to choose relevant sections for microscopic examination, leading to accurate diagnosis. The histopathological features analyzed dependent on appropriate and complete sampling by gross evaluation. Gross examination is the first important step in the pathology diagnostic process. Macroscopic finding is essential in the pathology report, which is integrated with the microscopic findings and clinical information to form part of the final diagnosis. For example, this is an advanced colon cancer showing type 2 morphology by colon fiber. After resection, we can understand macroscopically cancer cell may embed into the subserosa layer. Following microscopic examination revealed moderate differentiated adenocarcinomas showing subserosa invasion. Thus, to determine accurately T factor, pathologists should pay attention macroscopic examination on the cut surface of tumor. How about throat cancer? Although the number of throat cancer publication is increasing annually, studies addressing the macroscopic characteristics of PTC are very limited. Particularly, the association between gross finding and genetic alteration in PTC remains unknown. Therefore, this study aims to examine the impact of gross findings of resected PTC in the routine pathological practice. This case shows very characteristic macroscopic features of a certain type of cell nodule, such as capsulated smooth margin, solid brownish cut surface. US and CT also suggest smooth margin and undetectable lymph node swelling. Because of brownish color, we can estimate it in oncostick morphology as histological subtype. Following microscopic examination also revealed vascular invasion. Taken together these findings, this case was diagnosed as oncostick carcinoma, angioinvasive. If we can macroscopically recognize invasiveness of this tumor, it should be oncostick carcinoma, widely invasive. Thus, gross examination is critical as the first step of pathological diagnosis of thyroid cancer. From here, I would like to show our routine diagnostic practice by using following several slides. Our lab is collaborating with Yamashita Thyroid Hospital since 2018, which is located at Fukuoka. They send us approximately 20 surgical resected thyroid or parathyroid regions per week with clinical information, including US and CT findings, along with schematic surgical record and several macroscopic images of resected thyroid after fixation. This scheme tells us this thyroid tumor shows trachea invasion in CT image. So in our lab, we have a sign-out session for all of thyroid cases on every Thursday. As you can see in this photo, we are using two monitors to see both growth features and histological features simultaneously. In this case, macroscopically examination revealed an irregular roulette-shaped invasive solid whitish nodule. Microscopically, this case was PTC, showing hobnail and microscopic growth pattern as a phenotype of loss of polarity or loss of cell cohesiveness. And stromal desmoplastic reaction is seen in the invasive front. And not only staff members, but also a lot of graduate students from the different countries such as Kazakhstan, Belarus, Vietnam, Kyrgyz, Chinese, are working in our lab to gain their insight of cell pathology. After then, immunohistochemistry or Ki67 demonstrated a high labeling index such as 12%, suggesting a risk of aggressiveness of this PTC case. BRAF V600E was positive, and P53 was focally BRAF positive. Our pathological diagnosis in this case was PTC with aggressive subtypes such as Hovnell and microscopically micropapillary pattern and a high key system level index. Then we additionally reported TERT promoter mutation status by droplet digital PCR. TERT promoter mutation was detected in this case. Therefore, we concluded this case had a high risk for recurrence. Although the prognostic value of the BRAF V600E mutation remains controversial, several studies have consistently indicated that the TERT promoter mutation represents a potential prognostic marker and often coexist with the BRAF mutation in PTC. The combination of BRAF V600E and TERT promoter mutation is significantly associated with tumor aggressiveness, radioactive iodine refractory cancer, and the worst prognosis of PTC in patients, whereas either mutation alone has a relatively mild impact. This another study also reported a potential impact of TERT promoter mutation as a prognostic markers of a PTC. And Ki67 level index higher than 10% had an independent prognostic value of PTC. Combination of these two independent factors significantly associated with recurrent-free survival, as you can see in this figure. Indeed, this case showed the recurrence at trachea and right post-clavicular soft tissue at 3 years after the first surgery. As you can see in the US and PTC scan. Furthermore, FNAC from post-clavicular metastasis suspected anaplastic carcinoma. Papillary strain shows pleomorphic large atypical cells mixed with spindle-shaped cells. Histological examination demonstrated differentiated PTC in buried trachea, but anaplastic component in right post-clavicular metastasis are demonstrated. Immune stain showed P53 BRAF positive, but negative for TTF1 and thyroid in anaplastic components, suggesting they differentiated from the well-differentiated component. Ki67 level index was significantly high, such as 25%. BRAF positives suggesting originated from PTC, and loss of membrane expression of beta-catenin reactivity, suggesting a kind of the EMT. Therefore, we could diagnose this case was a recurrent or metastatic PTC with anaplastic transformation, showing TERT promoter mutation and BRAF mutated. So, like that, we have established this routine diagnostic practice between two facilities, 200-kilometer distance. Etching staining slide and FFP tissues are delivered from hospital to our institute, while all clinical data, including macroscopic images of resected thyroid, are transferred through website. Pathological diagnosis, along with microscopic images, is returned to clinician through web within 5 days. Additional data, such as mutation status, are also reported through website. Thus, I believe that good communication between two facilities, 200 kilometers apart, with exchange integrated data, including mutation status, is very critical to treat PTC patient adequately. Because of my specialty is pathology, I am not familiar with US features. But I understand that the US features can be used to estimate the malignancy of thyroid nodules. There are 3 thyroid imaging reporting and data systems by US. For example, European Thyroid Association guidelines reported 5 tiers US malignancy risk categories with risk of malignancy. US features to estimate high risk include irregular shape and margins. Additionally, some US features, such as solid composition, lobulate margin, hypoechoic, and so on, are closely associated with the malignancy of thyroid nodules. More recently, this study indicated US features such as multifocality, taller than wide shape, microlobulative margin, capsular involvement were closely associated TERT promoter mutation in PTC. Therefore, we guess gross examination of resected PTC should be associated with US finding, and which is TERT promoter mutation status. In addition, because TERT promoter BRAF gene mutation and Ki67 index can be a good indicator to estimate the prognosis of PTC, we focused on macroscopic features of resected thyroid with PTC and associated with coexistence of both mutations. This scheme shows the number of participants in this study. We retrospectively screened the medical record of 1,936 consecutive PTC patients who underwent thyroidectomy as the first surgery at the Yamashita Thyroid Hospital between 2018 and 2023. Among them, data on the status of both BRAF and TERT promoter mutation were available for 532 patients. Subsequently, 157 patients with tumor sizes smaller than 1 centimeter were excluded because of the rarity of TERT promoter mutations and excellent prognosis in most cases. Ultimately, 375 patients were selected for evaluating in this study. These images show classification of tumor margins of resected PTC in this study. Smooth margin, well circumscribed, and smooth pussy type boundary. Irregular margin is a pointed portion at the tumor border, highlighted by green arrows indicating irregularly protruded margin. Lobulate margin, round and consecutive protrusion at the tumor border, depicted by red lines, showing consecutively lobulated shape, ill-defined margin. Ill-defined margin not clearly distinguished from the surrounding cell tissue. This slide shows classification of the cut surface of resected PTC. Papillary excretion on the cut surface are occasionally observed. Upper panel shows a microscopic and microcystic and solid pattern consisting of delicate papillae mixed with dot-shaped yellow-whitish components. A lower panel shows solid and cystic cut surface, respectively. Papillary excretions on the cut surface reflecting microscopic, slender, extended, and complex branching papillary growth patterns with some bodies or scant organelle stroma. This slide shows a higher magnification of papillary excretion. It is composed of microcystic change and solid one, and papillary dedicated, fragile ones. And there is some whitish color and yellowish colors. So yellowish color is reflecting this stromal hyalinization and some bodies. The clinical pathological and molecular feature of the PTC cases are summarized in this table. Among 375 cases studied, the median age was 53 years, and the age of 47% of patients were older than 55 years. The median tumor size was 1.9 centimeters. This included 45% cases with a tumor size larger than 2 centimeters. Regarding the gross appearance of tumor, we found smooth margins, irregular shape, lobulate configuration, and ill-defined borders in 16.8%, 70.4%, 8.5%, and 4.3% cases, respectively. Papillary excretion crescences were observed in 14.4% cases, and solid cut surfaces were recorded in 76% cases. A total of 18% patients were negative for both BRAF and TERT protein mutations, while 21% patients harbored both mutations. There were 60% patients who were positive for BRAF but negative for TERT promoter mutations. Additionally, 0.8% cases carry TERT promoter mutations without the presence of BRAF mutations. The key 67 library index was more than 5% in 57% patients. At the time of diagnosis, distant metastases were identified in 2.4% patients. The median follow-up period was 49 months and recurrence occurred in 3.2% patients. The univariate analysis indicated a significant association between W mutation and age older than 55 years, tumor size larger than 2.2 centimeters, low-grade configuration, papillary excrescences, extrathyroid extension, T7 library index, higher than 5%, and recurrence. Multivariable analysis revealed that relatively old age, large tumor size, low-grade configuration as the tumor margin, papillary excretion on the cut surface, solid cut surface, extrathyroidal extension, and T7 library index higher than 5% were significantly associated with the W mutation. So as you can see in this Kaplan-Meier survival curve illustrating disease-free survival, W mutants showed significantly poorer prognosis. Similarly, PTC cases showing both low-related configuration and papillary excrescences as growth features exhibited significantly poorer DFS. The association between DFS and clinicopathological and molecular features was investigated. In the univariable analysis, low-grade configuration, the presence of papillary excrescences, and the W mutation were associated with DFS. However, in the multivariable analysis, only the W mutation remained correlated with DFS, and its hazard ratio was 7.8%. If we analyze hazard ratio for DFS by adjustment with these factors such as age, sex, size, N factors, EX factors, coexistence of low-grade configuration, and papillary excrescence were associated with DFS. Thus, the coexistence of low-grade margin and papillary excrescences is useful in predicting DFS in patients with PTC. The latest version of WHO classification of solid tumors newly defines a high-grade follicular cell-derived non-anaplastic thyroid carcinoma, which includes both poorly different thyroid carcinomas and high-grade different thyroid carcinoma, HGDTC. Especially high-grade GDTC is a new subtype of carcinoma. They are rare, ranging from less than 1 to 6.7% of all thyroid carcinomas. Lower prevalence rate are reported in North America and Japan. Clinicopathologically, this histotype develops rapidly growing masses, often larger than 4 centimeters, extends beyond thyroid, involves the other organs, and exhibit aggressive features. So we investigated HGDTC since 2018 through 2023 in a lab. Criteria for HGDTC is DTC showing mitotic features 5 or more mitosis per 2 millimeter square, or presence of tumor necrosis. Evaluated factors are following, such as LP-LCC component, T67, TAS promoter mutation, and recurrence. So as you know, LP-LCC component were reported as histological characteristics found in the invasive front, showing micropapillary organelle or isolated cellular components, which are suggested to be a predictor for tumor aggressiveness. These photos are tau cell and LP-LCC components found in HGDTC, which are known as aggressive subtypes. So we found 27 cases of high-grade DTC among 1,148 cases of very differentiated cell carcinoma, which shows larger than 1 centimeter, which calculated at 2.3% frequency. As compared with the usual WDTC cases, high-grade DTC cases significantly showed older age, a larger size, higher Ki67 level index, higher frequency of TERT promoter mutation, and higher recurrence rate. If we focused on high-grade DTC originated from PTC, almost all cases exhibited tumor necrosis and LP-LCC component. Furthermore, gross appearance of lobe configuration or papillary excrescences were found in 54.5% of high-grade DTC with frequent TERT promoter mutation rate. Thus, high-grade DTC derived from PTC may be closely associated with gross appearance of lobe configuration or papillary excrescence. So in summary, we found that the double mutation in PTC was significantly associated with relatively old age, large tumor size, lobe configuration in tumor margin, papillary excrescence on the cut surface, solid cut surface, extracellular extension, Ki67 level index, and short DFS. So importantly, the relative frequency of lobe configuration was 16 times higher in the patient PTC with a double mutation. So, and 30.8% of PTC tumors carrying the double mutation exhibited feature of papillary excrescence as a gross appearance, and a significant association of high Ki67 level index or lobe configuration in tumor margin, but no significant association with papillary excrescence. And almost 90% of PTC cases with the double mutation showed a high Ki67 level index. And this study is the first to investigate the association between macroscopic features and the status of two gene mutations with other clinical pathological features of PTCs. So we conclude that gross examination as a first step in the cell pathology should be a critical step to estimate the histotype of aggressiveness of cell cancer. Taken together with following steps such as microscopic examination and molecular analysis, we can accurately diagnose the cell nodules to contribute the treatment for patients with cell cancer. So of course, this study has limitations a lot. First, conducted retrospectively at a single center, which may introduce selection bias, and lack of ultrasound features, and we cannot compare with these features with gross appearance. And relatively the short median follow-up time, such as 49 months, and low recurrence rate limited our ability to assess the impact of macroscopic factors in DLS. Therefore, multicentric prospective studies with large sample size and prolonged follow-up durations are expected to further clarify our findings. So let me introduce our collaborator other than our postgraduate student. So in ABDI, 5 doctors are engaged in these studies. So their specialties are various, such as molecular pathology, endocrinology, molecular oncology, and human genetics. And of course, thanks to the Masahiro Hospital surgeon, Shinya Sato, Hisakazu Shindo, Hiroki Yamashita. So thank you for listening. This photo is taken in the Nagasaki Peace Park. This is a peace memorial statue. And in Nagasaki, spring, a lot of cherry blossom is found, especially in this Nagasaki Peace Park. It's a very famous site to see the cherry blossom. Thank you very much.
While we're waiting for Dr. Ghossein, I'd just like to thank Dr. Nakashima. I'd also like to encourage our listeners to send in any questions that they have that we're happy to try to address today. Ronnie?
In the next 5-6 minutes, I'm just going to to talk about Dr. Nakashima's paper, and also just address some of the issues that are of practical value. So I have no financial disclosure. I would like first to congratulate him and his group for a very good paper. I mean, this is actually, as he said, the first paper to correlate growth finding and molecular iteration. For those of you who are not pathologists, you have to realize that we pathologists, the last, would you say, maybe 60, 70, 80 years, have really neglected the growth findings. Like the new generation of pathologists are not very good in assessing the value of the growth finding. The quality is, the pictures are superb. It's not that easy to take nice pictures of growth findings. Now, this paper confirms the remarkable correlation between genotype and phenotype in follicular cell-derived thyroid carcinoma through many papers, through hundreds of papers that have been done in the last since 1990, maybe, since we start to understand the molecular, including the very important Cancer Genome Atlas project paper, where 500 papillary carcinoma were genotype in the United States, funded by the US government. This is the first time, in addition to the very good correlation between microscopy and mutation profile, we see that there is also a very good correlation between growth findings and phenotype. So everything follows each other, and we're lucky, we in the thyroid world, to have this great correlation. More importantly, I think this paper confirms the worst outcome in tumors with the double BRAF V600E and TERT promoter mutation. Now here we start to, at least by univariate analysis. Now, this brings me to, in my opinion, the limitation of the paper. First, I would, of course, it's not possible to put everything in a paper, and money is limited, but it would have been interesting to know the molecular profile of those cases that were negative for BRAF and TERT, where they're RAS positive tumor. I have no idea. I would have liked also the histopathologic analysis to be more comprehensive, more granular. For example, there is a specific histologic typing of the what so-called aggressive form of papillary carcinoma. This is another discussion, but I don't know too much about the vast majority of cases. How many were classic? How many were tall cell? Maybe are there invasive encapsulated follicular variant of papillary carcinoma, which for those of you who are not pathologists is a very different tumor from papillary carcinoma. It's basically a follicular carcinoma with clear nuclei. One thing I disagree, maybe Dr. Nakashima can tell me if I'm wrong, but when I read it, maybe I read it quickly, it looks like in the bucket of gross extrathyroid extension, cases with microscopic muscle invasion were included. Now, this is where, pathologists, we have disagreements, like surgeons have disagreements, like endocrinologists. I'm not a big fan of Ki-67 in thyroid carcinoma of follicular cell origin, because in the many papers they have done on the subject since 2006, it's not great. It doesn't correlate very well with grade and with outcome. Actually, one of the proof is that very well-known study, if you see the Ki-67 by itself did not correlate with worse outcome on multivariate analysis. I think the p-value was 0.56 or something like that. I personally I'm a big fan of mitosis and tumor necrosis, because we have shown again and again in many papers that this is first, it was neglected a lot by the previous generation of thyroid pathologists, and it is really a very important component of stratification of the patient. That's why we put it in the new WHO classification. So just a few more minutes, Mark, to show you how powerful is mitosis necrosis. I'm very happy that Dr. Nakashima has data on this that I didn't know, because it was not included in the paper. So I just want to very briefly repeat what he said. So high-grade differentiated thyroid carcinoma, the bizarre word, it has two important terms: high grade, because the tumor has a high proliferative grade. the engine is turning, like there's a lot of mitosis and or tumor necrosis. But in addition, differentiated because it retains the cytoarchitecture features of well-differentiated thyroid carcinoma. For example, it has papillary carcinoma nuclei. You have to tell you that 10 years ago, 12 years ago, many of these cases when they occur in your patient were called just banal papillary carcinoma. So that's why we brought this, because they have a much, much worse prognosis than your banal papillary carcinoma. To make it easy for clinicians, this is like a papillary carcinoma that, or a follicular carcinoma that's really gone bad. Now, why it is worse, just from this paper that we published in Memorial in 2022, the 5-year disease-specific mortality mark is 30%, which is much worse, of course, than regular papillary carcinoma. Now, we published very briefly a paper last year where we compared the tall cell papillary carcinoma, the one without mitosis and necrosis, and those who have mitosis and necrosis, and thus will be called high-grade differentiated thyroid carcinoma. You notice something interesting, a little bit confirms maybe Dr. Nakashima's paper, that we had 59% TERT promoter mutation in the one with mitosis and necrosis, where 34% in the regular tall cell, so to speak. But here you can see that the high-grade tall cell correlate with aggressive features like older age, larger tumor, very importantly, much more gross extrathyroid extension, of course, a higher grade. And you can see here actually that when you take, when you put mitosis and necrosis in this tall cell, they do much worse than the regular tall cell. Actually, without mitosis and necrosis, and this mark will shock you, tall cells are not that bad actually, and that's what Dr. Jatin Shah always thought, and he was actually probably right. Now, we did a multivariate analysis, and this high-grade tall cell, the one with mitosis and necrosis, were independent adverse prognostic factor in disease-free survival. The problem that we didn't have enough cases with TERT promoter mutation to test TERT promoter mutation, and that I would have liked to see in our paper and in Dr. Nakashima paper. All right, so now let's go to what really matters, because after all, this is involved patient. So the first question, should growth features prompt genotyping? Like, should you, every time you see a tumor with a lobulated configuration, jump and generate molecular testing? Personally, I think no, but I'm sure some of my colleagues will disagree with me. The question, which comes to Dr. Shah and Mark, so, okay, you take a tumor and after thyroidectomy, the patient is anxious, they do BRAF genotyping, and it's a doublet, BRAF V600E TERT promoter mutation. Are you gonna give targeted therapy? Are you gonna give more treatment? And probably more important for me, what to do with a patient that comes to you, and on the TIRO-seq, because it's done often in the United States, I don't know in Japan if this is done, you have a doublet. Should you go ahead and do total thyroidectomy and take the lymph nodes? So I think this will be the interesting point of discussion. And again, congratulations for this very good paper. So I'm done.
Great. Thank you very much, Ronnie. Dr. Nakashima, would you like to comment on Dr. Ghossein's review?
So, first of all, I'm happy to hear from doctors about the high-grade DTC. I focused on the high-grade DTC in terms of gross appearance of this lobulated features and public excrescences. It is associated with high-grade DTC also. And in our lab, we are frequently doing the molecular analysis if it is over than 1 centimeter and high T factors such as T2 or T3 and elderly patient in both TERT promoter mutation and BRAF mutations. And we are occasionally doing about the mutation study and NRAS Q61 studies. And we are confirmed there is no RAS mutation in the our PTC groups showing the low-rated and papillary excrescences. So because of this is very typical to the PTC, like appearance in terms of the nuclear features. So, and showing the sometimes the BRAF chemical positivity in these tumors. And important questions for your studies. What should I do if we can know the W mutant is a patient after the thyroidectomy? Actually, I'm not a clinician. I don't know how it is managed in the clinical level. So I sometimes discuss about this W mutant with a clinician on the Clinicopathological conference through the website. So they are now is interested in the radioiodine refractory or sensitivity in these W mutant types. So because of W mutant type frequently shows radio ability, active resistance ability. So they want to know, especially for the TAT promoter mutation, a BRAF mutation status, if it is recurrent. And finally, questions. So we are used to trying to demonstrate the mutation status with FNA specimens. So it is working well with Doppler digital PCR analysis to see the BRAF mutation. But we don't know about the TAT promoter mutation status with this FNA. So we need to furtherly to do the examination with FNA specimens to detect these two mutations to see the diagnostic profile. So actually in Japan, ThyroSec is not available. But in our colleagues started to do the NGS analysis to with a relatively relatively fewer gene mutation associated with thyroid cancers. So with FNA specimens, they successfully detected this mutation with FNA. So I'm sure about in the near future, so in Japan, so we can do this mutation study with FNA samples in Japanese made NGS gene panels. That's it. Thank you.
Great, thank you very much. So I think one of the obvious questions here for both Dr. Nakashima and Dr. Ghossein, should this become standard practice? Should we be recording the gross features and including those findings, perhaps in a pathology report, but certainly to maintain a log of what the cross-sectional appearance looks like? I think I know the answer from Dr. Nakashima, but Dr. Ghossein, maybe you can comment on that.
Yeah, I mean, definitely a gross examination is very important for the pathology. It's like when you do a physical exam, whether you should reject a report coming from a small hospital in North Dakota because the pathologist doesn't see a lot of thyroid cancer, you can overcome the limitation of the the poor gross examination by microscopy, because this pattern of lobulate infiltrative, you will see it under the microscope. I think more importantly is to tell pathologists that you work with, if you're not in an academic place like you or me, is to really sample all the tumor as much as possible. That's really the key. Is sampling more important than anything.
Okay.
Yeah. I have a question for you. So if you have a patient with a BRAF and TERT on ThyroSeq, would you immediately do total thyroidectomy, tell this lady, you know, this is unfortunately a difficult thing, would you do more? Or would you, if the clinical and imaging features are not worrisome? Because it is possible he has a case of a patient with less than a centimeter. So I'm very interested in this. The reason I say Mark, because we just got a paper accepted in Thyroid where we published on TERT promoter mutation in ThyroSeq, 30% were benign, 30% were adenomas, with young women getting a total thyroidectomy for adenomas. So what is your approach at Mount Sinai West?
Yeah, so it's a great question, and it sort of dovetails into what does the surgeon do? It's a different question, but one that I want to get to. But that question comes up occasionally when molecular testing is done prior to surgery, and I think it depends on the clinical picture. If it's a very small tumor and there's no evidence of lymph node involvement and no evidence radiographically of extrathyroidal extension, I will do a thyroid lobectomy as long as there's nothing on the other side. With a discussion with the patient that if there's any intraoperative findings or postoperative findings, that might precipitate either an immediate completion or a delayed completion. That's my philosophy. If it's a larger tumor, perhaps approaching 3 to 4 centimeters, I will, under those circumstances, be a bit more aggressive. I certainly won't do a lateral compartment dissection. Let me see what Dr. Shaha says about that. Ashok, for that clinical scenario for preoperative counseling, what will you advise a patient?
You said it very well, Mark. You spoke for me. Our philosophy has always been more clinically oriented. And I think the paper that Dr. Nakashima presented is, between you and me, is no surprise to us that the clinical features are far more important than the molecular markers or even the final pathology report. The final pathology report, the only time we would change the philosophy is major vascular invasion, which we will not be able to identify clinically or even ultrasound or CAT scan. We are very particular at Memorial to get the best evaluation pre-op. And one of the points that you brought up, let's say there is a 3.5 centimeter tumor, BRAF, TERT, but no lymph nodes. That tells you upfront the biology of the tumor. This tumor is not very aggressive. And I think we feel very comfortable in the best interest of the patient to maintain the best quality of life with lobectomy alone. Now, if BRAF and TERT both are positive, then, and your tumor is intermediate size, like 3.8, 3.9, I would probably lean towards total thyroidectomy, or at least I'll tell the patient that these are the two right answers. In the best quality, I would do a lobectomy. We could always go back and take out the other side. What has remained unclear is, okay, you take out the other side, give radioactive iodine. Does it change the long-term outcome? We don't have any data on that. And that's part of the reason we are a little hesitant, including our endocrinologists who feel very comfortable if we do a lobectomy for unilateral, well-encapsulated lesion.
Great, thank you. I guess the one other question, which is a corollary to that, is the question of whether, first question is, how well do you think assessment of the gross appearance, how easy is that to be able for clinicians to be able to make those assessments about the lobulated margins, which seems relatively easy, but in terms of papillary excrescences, have you looked at how readily clinicians can standardize their assessment?
It's a question to me.
Yes.
Okay. So I think lobulated configuration is easier to recognize the everybody, especially in the larger tumors. So because of lobulated margin is we can define clearly. It is serially protruded margins in the tumors. So as I shows by the red lines, on the cut surface. So lower margins like that. So consistently, we can recognize lower margin. But in the papillary excrescences, so it is important to learn about what is excrescences. So I showed it in the two cases. So one is a very delicate, slender substance is seen in the cut surface. Okay, so it is reflected microscopic, a very long extended papillary component without a scant stroma, and sometimes they show the small hyalinization with a calcification. So if we can imagine about the microscopic findings in the papillary excrescences, so it may be increase consistency in the between the observer, intra-observer. So I think it is maybe it is possible to get the agreement to know the to differentiate, classify this morphology.
Great, thank you. I guess one of the questions then becomes, should surgeons be assessing the cross-sectional appearance in the operating room? I'm sure Ronnie and my pathologists are never happy if I cut a tumor in half to take a look at it. Ronnie, what are your thoughts? And would you feel comfortable with all your surgeons cutting the tumor and then acting on their assessment of the cross-sectional appearance here?
Yeah, definitely not. Sorry, definitely not. If you really want that, you can send a frozen section, but please, because we want to ink the specimen, which is of course very important, because the margins. You guys are wonderful surgeons, but sometimes you have a positive margin and you don't know it, and so forth. So no, absolutely not indicate, and absolutely no, absolutely no. Yeah.
Okay.
Mark,
So,
can I
yes.
make a comment? I think, in the olden days, we always used to cut the specimen. As the pathologists matured and our communication increased, I think we rarely cut the specimen now. We do feel it. We show it to our fellow that, look, this is going to be nasty. It is hard. It is fixed. It is to the surface. Occasionally, what I have done in a large tumor, like 3.5 centimeter, I take the specimen to the pathology. They cut it in front of me. So I get a better sense. Because I think, as Rani said, the margin evaluation is better done if we don't cut the specimen.
Yes, I got a very stern warning from Dr. Wennick, where I used to cut the specimen, and he threatened to cut my finger every time I cut the specimen. So I stopped. That was my stop there. So we have two questions from the audience, if we could get to them, about lymph node metastasis and double mutation. Dr. Nakashima, could you just comment on the incidence of lymph node mets for double mutation?
Yes, so if there is a external part of the neck lymph node metastasis, so it is frequently shows a double mutation, but it is dependent on of course, the histological subtypes. Of course, as Dr. Ghossein told us about the tau cell component or other kind of aggressive phenotypes, including hobnails or micropapillary subtypes, very important to think about the double mutation. Not only the double lymph node metastasis, but also other factors very important.
Great. Okay. Well, we are right at 9 o'clock here in New York. And I really would like to thank both Dr. Nakashima and Dr. Ghossein, as well as my colleague, Dr. Shaha, for all of your comments and congratulate you on a wonderful session. Next week, we will be back again with Dr. Mathur looking at environmental factors and the appearance of thyroid cancer and thyroid nodules. So we invite you back next week. To everyone else, have a great day. And thank you so much for joining us.